So we'll pause the recording, and we're gonna get started for today. And let me make sure everything's good. There we go. Great. So welcome to week 3 of the boot camp. This is actually a really crucial component because this is really hard. Some of the stuff we're going to talk about today is really hard to learn on your own. I can attest to that because I had to learn a lot about propensity score matching early on in my learning about TriNetX. And I had to rely on a lot of videos and learning about it from the TriNetX people and things like that. So I'm trying to really condense a lot of the components here into something that's going to be simple enough that ideally it'll be easy to follow for future projects. And hopefully we'll save you a little bit of time in understanding this. However, there's a lot of nuance, and it's not always easy to find a way to describe this in a way that's going to cover every project or range of projects. So feel free to ask questions if you have them. Book time with me if you need to through my website, and I'll put that in the chat as we go. And yeah, as always, I'm Daniel Novak. I'm Director of Student Scholarly Activities here at the School of Medicine. I run this boot camp every year to help students get familiar with the TriNetX platform, so we can help support you in creating the highest quality scholarship possible through the platform. And we're seeing some really incredible stuff. We have one student's paper just got into publication, was released today. So in the Journal of the American Academy of Dermatology's International Edition. So I think that's really cool. It's I think a great data set, and I think it's a great approach. So there's a little bit about myself in case you have any interest or questions. As always, quick disclosure is that I don't have any funding or formal support from TriNetX. I work for the School of Medicine and for the state of California. I don't have any relationship with them. Some of the salary time for this was covered by my U54 grant last year with City of Hope, which is a federal grant, but it didn't actually go to pay directly for this. It was more just a part of my larger coverage of my salary and stuff like that. So there's nothing to report in terms of conflicts of interest. In terms of where we are in our topics, last week we discussed defining and exploring cohorts in the Cohort Explorer and developing your queries and defining cohorts really carefully. Before that, we talked about in week 1 the general navigation and development of a project. And this week we're moving on to comparing cohorts and propensity score matching, which is part of the kind of real crux of the value of this system for students who are interested in conducting research, especially in areas that are, in some cases, very hard to research, or where it's hard to do a single center prospective analysis or develop a prospective study around it. In this bootcamp, again, you're going to learn about the TriNetX interface, identify worthwhile projects, compare outcomes between patient cohorts, and today use propensity score matching to reduce confounders and those kinds of things. We're going to talk a lot about what is a confounder, what does that mean, how do we know when we're seeing them. From the news, there's just an example. I was reading the news the other day, and I found a study on Ozempic that it was written about in the popular press. This is in science.com. And in this study, in this article, they were reporting basically on a study that showed that Ozempic could reduce risk of cancer for diabetes patients. And when I looked at that study, I was like, oh my gosh, there's no doubt in my mind when I saw this public article about it, there's going to be a TriNetX-based project, because it's one of the only ways to do a large enough retrospective analysis of those kinds of things, of GLP-1s and related similar kinds of hormones, right, that are being used to treat diabetes and obesity. And sure enough, when I saw it, it was in JAMA Open. The study was conducted very thoroughly, and you can see here, these are some of the features of it that I described in session 1 that they did very well. For example, their cohort diagram, they have a really nice, over here you can see a really nice forest plot that you can develop of looking at a number of different outcomes to see which ones are above or below hazard ratio levels that would be expected. You can also see some of their really great tables, tables galore for this study. You can see how they have the propensity score matching table constructed this way, and also their table describing all of the different ICD-10 codes that were used to construct the study. And what's really great about doing it this way is it's 100% clear to your readers exactly how you structured your study, what covariates you used in your propensity score match, and what codes you use to construct your cohorts from the beginning. So, I highly recommend taking a look around at some really good examples like this that are on our Scholarly Activities portal. But what's even more interesting is I took that example a year ago, and I just read another study yesterday that found that some of the newest GLP-1 drugs that have come out and been approved in the last year or two, like tirzepatide, in the UK, there's been a recent spike in the number of adverse effects, adverse outcome reporting going on in their public health monitoring systems. And what's really interesting was this: I was reading about that. That is, its own large-scale data set that they use to track, with pharmacovigilance to avoid some of those negative outcomes. But as I was reading through this, I was like, I bet there's a TriNetX study underpinning some of this discussion here in the popular press. And sure enough, right away, one of the first studies they cite in terms of looking at pancreatitis and GLP-1 receptor agonists is one based on TriNetX in this MDPI journal. It's an okay study, but I do think that it's really an object lesson in how some of these studies can really make it into the press and into the public sphere, so you can have an impact in developing these, because in a lot of cases, this is one of the only ways to develop those kinds of analyses. So, maybe that could be a motivator for some of you who are interested in developing projects in areas that are really hot topic and that need a lot of investigation. You can use that to think about how you might want to position your future studies. Again, here we are. If we look at it by feature in TriNetX, if you think about my clumsy metaphor of the house and the foundation, we're starting to move into the development of the house, which is really more of the analysis stuff. It's kind of the more, fun stuff, I think, in some ways. But we're going to be talking about choosing an analysis tool, index events, cohort comparisons, baselines, and balancing cohorts, and propensity score matching today. And next week, we're going to talk specifically about the outcomes and interpreting the stats involved. In our broader rapid development process, you can see we're in the compare cohorts and propensity score matching phase. And in the even more rapid phase, we're in pulling out the key features, reconstructing the study in TriNetX, and refocusing the structure on your topic and cohort. Again, here's the foundation that we built in the last couple, which is cohort exploration and looking at confounders. We're looking at now the analysis type and cause and effect order, and using propensity score matching to reduce some of those confounders out there. And again, we're returning back to our example study, which was inspired by this piece of internet clownery about Alzheimer's being a physician-created disease caused by the overprescription of statins, and that Alzheimer's didn't even exist 40 years ago, and that's why it's a complete scam, and that statins are really the cause in that overprescription. None of that makes any sense, even just basic factual knowledge. But as I said earlier in lecture 1, it was worth investigating a little bit to see what this relationship might look like, and to see if there's a way that we can shed, using this data set and this analysis platform, so a little more on that. So you can see we've developed our hypotheses, and we're moving ahead with the analysis of them. And we're going to address this in 2 chunks, the analysis phase. As I said, this week we're going to assess the kind of pre-analysis, and next week we're going to look at the outcomes and stats. So TriNetX has a lot of analysis tools built into it, and you may be familiar with some of it from having done some of your own work so far. But once your cohorts are done, hooray, our cohorts are completed. We've completed some really nice development for them. We are clear on our time and cause and effect relationships. We are certain that we have the right groups of people in here to conduct our analysis. Now we can go on to this window you can see over here on the left that says analytics. And that's where we're going to be able to move on from just pooling up people into like cohorts and looking within those cohorts, which you can use using some of the features I described last week, like the explore cohort function, where we can look within this cohort of people. Now we can compare between cohorts. You're going to look at a screen something like this that says My Analyses. You can see I got a bunch of them like lined up here. But if you're going to create a new one, there's a blue button in the upper right-hand corner called New Analysis that you're going to click. And when you click on that, you're going to be given, you can see there's a little box around it right here. You're going to be given a series of different choices, right? And I'm going to take you through them a little bit to describe what they're for. The most common one, and the one we're going to look at in this bootcamp, is the compare outcomes function, but it's by no means not the only one. It just actually contains within it a number of other analytics tools that you see on the screen. So session 5, actually this year, I've expanded to include these additional 2 tools, treatment pathways and the Cox proportional hazards model, because I have been getting a lot of questions from people that can be answered really nicely with some of these tools, and understanding them better will help you guys plan that, so you're not really hacking away at using the compare outcomes tool for a tool that's better suited for the Cox proportional hazards model. There's really no best analysis tool, though. It depends on having your clear focused questions. Your question about time, order, and sequence, well, that's going to require one set. Is it about a specific relationship between different cohorts and their outcomes? Or is it a question about relative risks and who has a higher risk of having a particular disease or not? So your analyze cohort is a single cohort function that's going to allow you to look at whether, what outcomes one particular group of people have. There's just one example of some students came up with of pregnant individuals who have very rare diseases. There's not really a comparable cohort for people with very rare diseases who are pregnant, because comparing them to all pregnant women doesn't really make any sense. That rare disease, it puts them so outside the range of normal comparison that there's really no point, as far as I'm concerned, in comparing them to every other pregnant woman in the world who has all sorts of other stuff going on with her, potentially. So looking within that cohort and seeing what percentage of people in that cohort of pregnant women with a particular disease, or birthing people with a particular disease, that might be more of interest to you than creating a false comparison compared to all people in that who are pregnant. Similarly, competing risks, you might be interested in just the risk between 2 cohorts in a particular outcome, or for having a particular feature in them, say all pregnant women, or pregnant women versus pregnant women with a rare disease. That can be something that can be very interesting. We're going to talk again, as I said earlier, about treatment pathways which is when and what order did patients receive particular treatments, particular drugs? Did they get metformin first, then get semaglutide, or did they go straight to semaglutide, right? What percentage of people on that? That tool will also tell you how long people were on those drugs for. So how many years have they been on semaglutide for on average, which could be really valuable for your study, especially if they're serving as a control group. Incidence and prevalence can be helpful for how frequently do particular events occur in the cohort. However, it's often the case that it really doesn't tell you as much as you'd like it to tell you about what's going on. For example, we had folks using the incidence and prevalence for a lot of stuff related to pre-post-COVID outcomes. And all we really saw was that everything went up after COVID, because during COVID, nobody was getting seen for medical treatment. And afterwards, everything went back to normal and even above, right? People were more sensitive to their health. So incidence and prevalence can be a tricky tool to use, but it can be useful. And the Advanced Cohort Explorer does give you some additional features for digging into one cohort studies as well. Your 2 cohort comparison tools are that compare outcomes that we're going to look at today, and also compare cohorts that allow you to compare the composition of cohorts to each other. So what percentage of people in my my cohort with obesity versus my cohort not with obesity are on metformin or insulin or something like that. That can be used in the compare cohorts function. So you can really see across all of these different tools, there's different functions for each of them. And they really can help you depending on what exactly you want to do. This covers a broad range of epidemiological and clinical questions that you may have. The Cox proportional hazards model, which I didn't include over there, allows you to do even more. And we're going to talk about this in more detail in the future. But it allows you to basically look at an unlimited series of covariates, however many you want to include in there, and how much each one contributes to a particular outcome that you're interested in. So in this case, I have 2 mutually exclusive cohorts. One has had statins and the other has never had statins. And otherwise, they're very similar. when they get thrown into the TriNetX flavor of the Cox proportional hazards model, it'll then allow you to say, how much does being white contribute to that? How much does being black? How much does this contribute to the outcome of Alzheimer's disease? So it's really useful for looking at how much more likely any individual factor in this statistical model is to make you more likely to have that outcome. So it can be really, really useful on that. And we're going to talk at length about that later on. Again, the cohort comparison is the one we're going to use because the two cohort outcome comparison allows you to do things that include the compare cohorts tool and the competing risks tool. So in order to use this tool, you really have to learn those two other tools anyway. And we're going to go through those functions as we go as well. Partially because the compare cohorts tool is necessary to help you with your propensity score matching, and your competing risks tool is very similar to what we're going to look at in terms of looking at the outcomes between different groups. I believe that's actually going to come in the next session as well. So basically, once you've got your cohorts designed, you are going to load them up into this function. I usually put my cohort of interest, I'm not going to call it necessarily an experimental control, my cohort of interest in the purple, and then I put the control cohort in the green. I have that kind of flipped here, but that's how I used to. Now I do it so that you have your experimental on the left and your control on the right. And the reason for that is it then gives you a better set of numbers. It's easier to interpret the numbers that come out on the other side of this later on when we look at our outcomes next week. But first, we got to talk about a conceptual command. We're going to move through all of these windows here on the left-hand side because they each tell you an important piece of the process that's going to help you do the most interesting and most rigorous study possible. Actually, just before I move on, I got a question here. And you can choose as many tools as you want for a single study. Yes, you have an unlimited number of tools as you want in here. So once you've created your cohorts, you can use those same cohorts in different tools. Sometimes you have to reconfigure them a little bit to get the maximum out of the tool. Like, for example, if I wanted to know how many people in my overall pool of all people who eventually go on to have Alzheimer's, how long some of them were on statins for, I could use a cohort specially designed for that purpose and use the time on treatment function to look at that. But there's no mutually exclusive nature between that and other combined analyses that I'm going to look at. So you can have as many as you want in any given study. Though it's interesting because most published studies only tend to report one compare outcomes function. They don't use the other tools as complements, which I think is kind of silly. I think using time on treatment to help, because one of the first things editors are going to ask is, well, how long on average were people on your drug in the semaglutide or statins? And with that tool, you can say, well, in this cohort, the average length of treatment time for a person was 900 days. And then you can say, well, for about 2.5 to 3 years, most people were at least on the drug for that long. So that can be really helpful in establishing the validity of your broader study. All right, index events, really important epidemiological concept. Hopefully some of you might remember from your biostats classes or your epidemiology classes, but it's actually a feature that's baked into how this software thinks, which is great for me as an instructor because you have to learn what an index event is in order to even make use of any of this stuff. So the first thing we're going to talk about, as you can see over here where it says the analytics on the left, once you've loaded in your cohorts, the next window down is your characteristics cohort. And what the characteristics cohort does is basically create a backwards looking timeline for your group. And what this allows you to do is establish when your study starts, which of the series of events that you've defined your cohorts by. For example, on the left over here, you can see this cohort starts when somebody has had an ibuprofen or an aspirin and an office visit for any reason at all, but has never had any of the statins. Over here, this study on the right starts the day that somebody is old, over 45 years old. Actually, that's true of the other one as well. But when they're over 45 years old, they've never had any of these characteristics, and they've had a statin for at least 1 year. So we're looking backwards from the date of our study start into the patient's record of the past to see when they enter our study. And you can use this feature and the different index event definitions to subtly manipulate exactly how and when events occur in your analysis, which can be super useful if you want to make it so that certain events occurred in the past, but that the study starts before or after or any time in relationship to those events. But you can make it so that the study cannot begin until the person has a heart attack. We're going to talk a little bit about this in a minute, how an index event actually works in the software and in general. But basically, I know I'm dating myself here, but this is you can use this DeLorean, this time traveling machine here, to look into the patient's past as far as you want. This little time bar here allows you to define how far into the past the index event has to occur. For example, if the index event began with a person getting an ibuprofen and an aspirin and having an office visit, we could say we only want to see people who've had that in the last 5 years relative to their health record. Anyone who's had it 10 years ago, they're excluded. We want to only include people who had those index events in this time frame, and it stops there. So we can define how far into our past we're looking. This is a little confusing, but I think as you see how it unfurls and as we look at some more of the definitions of these things, I think you'll understand how this screen works out a little bit. And it is certainly something that I know causes a little bit of confusion when people are first starting out using the platform. What exactly is this doing? What's happening with this? But the main thing to remember is this is setting how far back into the past we're allowing our study to begin relative to the first event that we want to occur. So again, let's talk more formally about definitions of index event. Basically, index events, when we use them to look into the past or the future, we're saying in the past relative to what thing that occurred. Again, the day the person had the heart attack, that's the day our study starts, right? Before that, anything, we can define what occurred or did not occur before that. We can define what occurred or did not occur after that, but that's the anchoring date in our study. TriNetX defines it as to define an index event for each cohort, select one or more criteria for each cohort. Those are the little check boxes next to each component in your cohort. And the index date for each patient within a cohort is the day on which the patient first met all selected criteria for the cohort. And again, I'm just saying this in a couple of different ways because hopefully this will help explain a very amorphous concept, but put it as simply as I can. An index event is the first day at which all of the features you've included in your cohort definitions are true. So we'll take a look at that in a second, but the first day they had high blood pressure and received medication, if that's your index event, the study starts the day those things are both true for the person. They may have had blood pressure for years, but the study doesn't start until, as you've defined it, they get that medication in their record. I just want to show you this TriNetX example really quickly from their website because they do a really nice job of showing this graphically. I'm going to put this page in the chat in case you want to read this later. You're still having trouble with the concept of an index event and how it impacts your analysis. But let me scroll down a little bit in here to show you this concept of a timeline. So what this is telling us is basically every couple of months, this study is checking in on 4 patients, and they all have the same cohort definition diseases going on here, the same things occurring, but they're all occurring in different orders, right? This person shows up first with asthma and they're given albuterol, and then they have wheezing, coughing, sneezing, and they're given another drug. This person shows up, nothing happens, right? They're not giving anything. Then they show up the next visit, they've got asthma, then they get albuterol, then they have wheezing, coughing, right? Different orders of the exact same thing. So your cohort that you've defined, that includes somebody has to have asthma, they have to be on albuterol, they have to have wheezing and cough, and they have to be on montelukast and sneezing, and those all things can occur in different relationships in time. So depending on which of these boxes you check in your cohort definition, your cohort will enter at different points, right? So if asthma, starting and showing up with asthma as your index event is the first thing you want to occur, that means the study starts, regardless of when in relationship to asthma they had wheezing, coughing, and anything else. The study starts the day they have asthma. So patient number 3 over here has already shown up with sneezing, wheezing, cough before they enter our study, which may or may not be what you want for the study, right? However, patient number 1 and 4, they've already shown up with asthma, so they enter our study before they develop wheezing, cough, and then they show up again with cough and sneezing and that kind of stuff. So the order in which these things occur can be really important. Similarly, in this study, if you check albuterol, the study starts when they have had albuterol or this other drug, hashtag not that kind of doctor, right? This other, imagine an asthma control medication. So what we're seeing here is that the study, even though we have these two features, the study can start on different days, on different events, as far as a year apart from each other. And if the disease progression is important or linear in some way, right, where someone starts out with sneezing, wheezing, cough, and develops asthma as a result of that, or as part of the development of some larger disease process, well, that might be really important to how your study is constructed. So here we also have in this kind of third example, the idea that you've got wheezing as a characteristic, and in time relation to that, the wheezing occurred within 6 months. Sorry, the cough that the person develops occurred within 6 months, and that's the index event for our study. These other people would also have had asthma, albuterol, and other medications, and never had these other medications, but they have to have had these things within 6 months of each other. So you can see there are other people in here who had other kinds of constellations of conditions, but only the people with wheezing and then within 6 months of that cough. So this person had wheezing and then cough, this person had wheezing and then cough, this person had wheezing and then cough, and this person had wheezing and then cough. So those people are all included in that study. Finally, again, we can include it so that these people all had all of these conditions, right? All of these things occurred at some point or another in the past. However, there's a defined date between January 2017 and December 2017. So none of the people who had sneezing in 2016 get included in our analysis. So there's a couple more examples like this, but hopefully it'll help give you a little bit of a sense of how order can impact the kind of analysis you're doing and why it's so important to really, really pick your index events carefully. We'll just log back into TriNetX. As we're talking about that, do we have any questions about this concept? I know I've been going over it a lot, but it's very important to understand thoroughly so that you can get a very strong sense of some of the relationships between time and outcomes. Just gonna take a quick pause. Feel free to unmute yourself if you've got a question, or if you want to put it in the chat, I'm happy to help address that. All right, so nothing yet. So let's keep things rolling. Next, we're going to talk about the cohort comparisons in the characteristics menu. This is really important because we're going to use the characteristics menu to help spot confounders or mediators. We're going to talk about those definitionally in just a moment. And it helps to spot differences between cohorts that might be unrelated to chance. There may be some underlying feature of the cohort that's causing them all to express this common series of events or common set of medical outcomes. And those common characteristics can really mess up your analysis. And we're going to talk a little bit about how that works in just a moment. The first thing to do is once you've established your timeline and established your index events, and you're really clear on what features you need to come first and in what order and what the definitional components of your cohorts are going to be and how far back you're looking, you're going to hit the Run button in the upper right-hand corner on this characteristics time window page. And this is where I'm going to ask you to remember back to your doctors don't pay money late, your demographics, diagnoses, procedures, medications, labs, and genomics if you're going to use them. But this is really essential as part of our ability to look for confounders in the study. So after you've hit the Run button, it's going to take you to this page that says demographics. And what's really important about this demographics page is it's going to tell you how each of these, or basically how each group in your subset is represented in the cohorts. So your age at index is one of the most valuable pieces here because age mediates so much of medical research and it's not always accounted for properly. So in this study, you can see over here that my purple cohort, my no statin cohort, is on average 10 years younger than my statin cohort, right? And there's a pretty large standard deviation, about 11 years. So one standard deviation out, and you have people who are as young as 64 and as old as 76. And same here, you can have people as young as 44 and some people as old as, as young as 42 and some people as old as, 68, right? So this really helps us to understand that this is an essential feature for us to control for in our analysis, or we're going to wind up with some wacky stuff. Similarly, you're going to see down here male and female, which is really important. That mediates a lot of other variables for a number of reasons, both physiological and social psychological. So you're going to want to be aware of those and include those probably in your propensity score matching model later. And one of the ways that you can include this in your propensity score matching model is by hitting this little star icon over here. So later on, if you know you're going to want to control for age when you're doing your outcomes analysis, because you know it's going to be a confounder, you hit that star and it'll add it to your model later. And we're going to look at how that really works in just a moment. As I said, when you actually, now I might as well say it, when you check the little star button here, you're going to see that it adds it to the saved characteristics window over here on the bottom left, which is it says, as you click more of them, it'll tell you how many you're adding to your model, how many covariates you're adding to your propensity score match model, and it'll keep track of them for you. This is now as you move out of your demographics, you're going to see over here on the left-hand side, there are your diagnoses functions. This is going to basically tell you, comparing both groups along every single diagnostic characteristic prior to the start of your study. Now, this isn't what happens later. That's actually a different function. This is what's happening before. So how different are your groups going into the analysis? What it does is it essentially shows you all of the ICD-10 codes. And over here, you can see, again, in these percentages, our statins group. Let me find something a little more useful. Our statins group has been pregnant less on average than the no statins group, because the no statins group are younger. So before our study starts at age 45, more of them have been having pregnancies during that time frame. Really, only 3%. But if that's something that's important to your study, you can select that and have that added as a covariate in your study. What I'm going to call your attention to is this little it's called the signal icon. You can see it says signal at the top of the column. You can see it's got 3 bars. So much like your cell phone bars, what the signal does is provide a weighted statistical assessment of whether there's a difference between these two groups. So here you can see TriNetX, when you weight these two groups based on their population sizes and their percentages of the cohort, probably there's not a lot of stuff going on underneath there. There's really not, there's a little bit of a difference, about a 5% difference, but it may or may, based on how that's distributed within the subcodes, may or may not make much of a difference. However, you can see that this signal here shows with 3 bars that there's probably a lot more difference between these two groups on this front, and it's worth taking a look at. But I want to be clear, don't use that signal icon mindlessly. It is not a rule that you have to include every single thing with 3 bars. And you can see a little bit why, because down here, for example, there's only 65 people in one cohort, and there's only 4,000, which is like less than 1% of the other cohort. So there's really, really not much of a difference in these two cohorts between representation of these two groups. And depending on what you're working on, it may or may not be relevant to your actual analysis. So you don't have to mindlessly check every single box. I've met with some people who've had 50, 60 characteristics they're adding into the propensity score match model. And I'm like, why are you including this? And they're like, well, it had 3 bars. And I'm like, that's not a good reason to include it. You need both a mathematical reason, in this case represented by the signal, but also a theoretical reason why that's important. And you also really need to think about how much of an impact this is likely to make on your final analysis. So just to summarize, because I know this is a little bit hand wavy, it's going to depend on every single one of your analyses, but you should basically save a characteristic to your propensity score match model when the characteristic is plausibly relevant to differences in outcomes in your cohort. That means there's probably some sort of mediating relationship in here that might be a confounder or might in some way skew your data. And you have to be really, really critical about what you think those are likely to be. If it does have a strong signal or a large disproportion or proportional disparity, that might be another clue that you're going to want to include it, but it's not a requirement. And is something that you want to control for in your analysis, but you don't want to exclude the whole population of people with that characteristic, because doing so might create an artificial group of people. Like, for example, in this study of statins and Alzheimer's, if we excluded from our cohort everyone with hyperlipidemia, well, that's going to create a really artificial pool of people who are getting statins for unclear reasons, right? Because the majority of the reason people are given statins is because of hyperlipidemia or weird stuff going on with their cholesterol of some sort. So if removing those people, if we removed everybody with hyperlipidemia from our study, that wouldn't really represent the group of people that we're interested in. It would actually be kind of counterproductive. So including those people can be really valuable as we go. But we want to make sure we don't wind up with a situation where everybody in group 1 is relatively healthy and has a normal lipid profile, and everybody in group 2 has hyperlipidemia. That's really going to influence or impact our analysis in a way that is not productive. So you really need to think this through as you're working on it, and there's no single set of rules to guide it. You have to really think about it and use your brain and your knowledge of clinical medicine and biomedical sciences to do that. But we're going to talk about what happens once you've selected. So you've gone through your process of selecting all of these characteristics from you're looking for differences between rates of for surgical procedures. You're looking at different medications, different values in labs. You're going to look through all of those. Your doctors don't pay money late. And at the end of it, you're going to look across your comparison. And what this is going to allow you to do when you move on to this window down here called baseline comparison statistics, and you hit the run button, is it's basically going to tell you how different these cohorts are from each other using a t-test, right? Or sorry, in this case, a z-test, because it's a little more robust against large numbers. You all might recognize that our good friend, the p-value, right, is the difference between these two tests statistically significant between these two groups. You're also going to get our old friend standard difference. And a standard difference tells you basically how much of a difference there is between the two groups, right? Where, 1 is a very large difference and 0.1 is a very small difference, right? So between very large and large. Now you can have, because of the large, and in this case, enormous statistical pools we have, even small differences between groups can wind up being statistically significant. So that's why you need to use your standard difference to understand. In this case, 0.2 is a smallish difference between the two groups. But given that we are working on this study, and we're going to talk a little bit more about standard differences and understanding what is a small and a big impact. But given that we want to control for male and female representation in these studies, we probably want to include those. However, you can see here that the standard difference between our two cohorts, which are statistically significant, is 1. And 1 is a huge standard difference between the two groups. So that would indicate to us that difference is going to make a real big difference in our analysis later. And sure enough, it will, and I'll show you how. But just a little bit, if you're going to use these standard differences on your own, you can use this tool, not just to propensity score match, but if you really just wanted to do a comparison between two groups on a feature and just get a t-test difference, how frequently does this occur versus this in our two pools, you can use this function, this baseline comparison statistics function, to do that. And you can report that in your study, as part of your broader set of results. If you're doing that, though, I recommend you use one of two approaches to what's called an effect size. Again, an effect size is basically how much of an impact, how big the differences are between these two groups. Standard differences can be used to report those effect sizes because they're pretty similar, but a lot of journals, a lot of editors, a lot of reviewers are very familiar with Cohen's d effect size because it's the one used mostly in meta-analyses and systematic reviews. And Cohen's d is really great because it has a very easy to interpret number that I'll get to in a sec. But basically, it's not great if you have a binary characteristic like male and female. You need to use your standard deviation for that. But if you have a continuous variable, that is a number 1, 2, 3, 4, 5, 6, 7, right? A continuous value, you can use the Cohen's d to take the average, basically the mean of both of those groups, and the standard deviation. You can compute Cohen's d, and it'll give you a number between 0.0 and 0.1, oh, sorry, 1.0, where 0.2, as I said, is small, 0.5 is medium, 0.8 is large, and 1 is very large. The standard difference numbers are basically about the same in terms of telling you how much of a difference there are between them. And anything beyond 1, as we saw a little earlier, indicates a very large difference between the two groups. So I recommend that you compute this. There's calculators online for calculating Cohen's d from continuous variables. It's very straightforward math, but it'll do it for you and give you the numbers, and you can include those in the table. Please let me know if you got any questions. Feel free to put them in the chat if you've got any thoughts or questions on this, because we're about to dive into some of the deep end on some of the TriNetX stuff. This is a foundational concept that really divides people who I think really understand how to use the platform and people who are still learning. Because if you can get your arms around propensity score matching really reliably and do a really good quality job of it, it really helps to assure all of us that your study is well conducted, well designed, that you know what you're doing. That includes editors and everybody else. So what is propensity score matching? It's funny that that book I recommended, the clinical research book, calls propensity score matching a fad, that it's a newfangled statistical approach for controlling variance. And they're like, oh, you know, it's not well tested, but it has been tested for over 25 years. They've been working through this mathematical model to observe its very real limitations, but also its real bonus. One thing is it's very easy to use. Another thing is it makes a lot of sense prima facie in terms of how it allocates and understands variance between two pools. And the other is it's robust against a lot of different kinds of statistical variance that you might see out there. It does have its problems. I am also not a statistician like of that type. There are people who study specifically how propensity score matching, where it breaks down, what kinds of artificial, they create artificial data sets and Monte Carlo simulations and all sorts of wacky stuff to test the math behind this, to see where it breaks. And there are cases where other kinds of bias correction can be valuable. However, propensity score matching is very widely used and is very well understood. But basically, in the way that randomization is used to reduce bias between the two groups in a randomized control trial, to reduce both random variation, or actually to increase random variation and reduce selection bias, observer bias, all the different kinds of bias that we might face. There's like 24 kinds of bias that have been defined in medical research. We can use randomization to control for almost all of them. Well, observational studies can't really conduct randomization. We just have who we have who shows up. It's not really the way that prospective randomization, assignment to two different control arms, using all sorts of different really cool techniques that clinical researchers use to reduce and assess bias or statistical loading on different groups. We can't really do that. Even though our data sets are much larger than the randomized control trials could ever be, we really can't use random assignment this way. Propensity score matching kind of fills that gap, though. It's not as perfect. Nothing can be as perfect as randomization. And when they run statistical trials, it's not as clear as randomization can be, but it helps us to do it. So in technical terms, propensity score matching is a quasi-experimental method in which the researcher uses statistical techniques, in this case, a form of logistic regression, to construct an artificial control group by matching each treated unit with a non-treated unit of similar characteristics. Using these matches, the researcher can estimate the impact of an intervention. So when we talk about it, I want to break down a couple of things here that are really important. The first is it's an art we're constructing from our original pools of people in our cohorts to groups where we are statistically trying to reduce the amount of, let's say, bias that's inherent in those. So we're using that, for example, if we have a group that is much more male than female in our cohort 1 and our cohort 2, there's a skew in both of those, we can use propensity score matching to create a sub cohort of people that do not possess that bias in there, that it's much more randomized, so that along those characteristics we defined, there's no systemic bias or no systemic orientation towards having one set of characteristics versus another. I know that's still really confusing, but basically, once you select a series of covariates, let's say age, type 2 diabetes, this and that, you create a whole laundry list, whether the person is Black, white, Latino, or Asian, whatever characteristics you might choose, it sets those as a baseline characteristic, and it assigns a score to people based on how likely they are to be in group A or be in group B. And that likelihood represents whether there's some sort of bias towards being in group A or group B. So in my statin group, there may be a bias for people with hyperlipidemia to be in my statin group and not so much to be in my control group. While there still may be people with with hyperlipidemia who are not on statins in my control group, I want to make sure that my analysis isn't just telling me whether people on statins get statins, right? I want to know whether people on statins wind up going on to be at a higher risk of getting, whether people on hyperlipidemia get statins. We want to know whether people with statins get Alzheimer's. So you can see here, basically what you can think of it as the propensity score itself is a value assigned to each individual. So you have 2 million people. It computes a score for every person and creates a distribution based on the natural log that is unlikely to be occurring by chance. And then it matches them 1-to-1. So a person with a score of 0.8 likelihood of being in that group, they get matched with somebody else with a likelihood of 0.8 for the other group, 0.7, 0.6, 0.5, 0.4, 0.3, all the way down until you get as many people in your smaller cohort matched to as many people in your larger cohort as you possibly can. And ideally, when that's done, if you've done everything nicely, you get a distribution that is not systematically different. I'm not going to say they're not randomized, but the factors that you've included to propensity score match by are not statistically more likely to appear in one group than in the other. One challenge can be that if you have a very small group of people, you can have trouble matching them with people from your other group if you also have a very small group of people. So you need kind of a big group, or at least if you have a very focused small group, you need a very large other group to match people back and forth. And that can be a little bit challenging to do. So you need adequate sample sizes. You can run into residual confounding. One unfortunate side effect in TriNetX is we don't get a confounding or a residual statistical metric for our model. So we have to kind of assess based on the number of factors how likely this is to be covering all of our bases. And there's a couple ways we can do that. But propensity score matching is a great way to help make sure that we don't have a range of different biases represented in there. Now, I can't do anything about the fact that whoever's in our data set is just whoever's in our data set, right? They might be people who are more likely to go to large hospitals because they live in urban areas. So if they're in Chicago at Rush, they're more likely to just show up there because they live within walking distance. So you're going to get more of an urban population represented. However, ideally with TriNetX, because it's a national and federated data set, you might get the person going to Rush in one place and randomly somebody in Iowa who lives in a very rural area driving into Davenport to go to University of Iowa's health system for their medical procedure. And thus we can hope that if we have 100 million people in our data set, we can find ways to get that big random pool that would reduce the risk of some of those other kinds of bias that we can't match for. So I'm sorry that was such a long description, but it's really important to understand, and I hope that I've done at least some justice to it. Unfortunately, if you read the Wikipedia page, there's like a lot of statistics jargon in there, so kind of understanding how it works can be a little challenging, but there are some great videos as well. But propensity score matching, I want to be clear, does not make your cohorts the same. There's a lot of times where I read students' descriptions of what it's doing, and they're not accurate, right? It doesn't reduce significant differences between the two cohorts. It creates new subcohorts that are sampled to balance along the factors that you're looking for to avoid systematic differences between groups based on your selected mediators, which is a long way to say that it tries to create new subcohorts that don't have the same inherent biases that your longer groups do. To make maximum use of this, though, you're going to also need to understand three kind of core concepts. What is, and to know whether you're going to select factors for your propensity score model, you need to understand a confounder is a variable that precedes both the exposure and the outcome and creates spurious associations. So we use that term all the time, right? Some sort of confounding factor that shows up in your study. And those and again, it's because the exposure and the outcome, the thing you're looking at and the condition of the individual that you're including in your study, both of those are being impacted by the confounder, which means it's really hard to tease apart cause and effect when you're looking at a confounder. However, a mediator is on the causal pathway between exposure and outcome. So that's one example is statins is a mediator for hyperlipidemia, and hyperlipidemia is mediated by some of these factors. So for Alzheimer's disease, so it can help excluding that from our study or other propensity score matching for it could, for statins rather, could skew our data set. So in this case, we know that the statins impact the person's hyperlipidemia, so it seems to be okay to have that because that's on the way to our causal outcome. We want to adjust for that confounder between the two groups that precedes both the exposure and the outcome. However, we don't want to include mediators. I just did a really bad job of explaining that. Let me try again. A mediator actually might be something like a stroke mediating other kinds of cognitive decline. So you're going to want to exclude people who have a stroke from your study because excluding them is going to allow you to get a very clear picture of the relationship between cause and effect caused by, for example, statins and Alzheimer's. Strokes are a mediator that can make that less clear. Similarly, an effect modifier is a variable where the exposure's effect differs across levels. That means it can mediate whether a person is impacted by something or not. So, for example, there might be other kinds of things you might want to propensity score match, like there are some limited kinds of socioeconomic status data or smoking that you might want to include that impacts whether a person is likely, whether because they're older or younger or male or female or black or white, might impact their likelihood of developing something. So those can impact how you choose to propensity score match or not. So when should you exclude and when should you propensity score match when you've got something that's a confounder? Well, when something is a confounder and it affects both the exposure and the outcome, you're going to want to propensity score match for it. When something, and you're going to want to balance the groups based on those pre-treatment factors, and this preserves your generalizability and adjusts but doesn't alter your population. Similarly, if you have a modifier or mediator, you're going to want to exclude those because they can introduce all sorts of heterogeneity, all sorts of complexity into your model that can't be adjusted for using the propensity score match. So in my case, as I said, stroke can be a mediator for all sorts of dementia. So I kicked all the stroke patients out because I don't want that to be to influence it. There's no way in which propensity score matching for it would reduce the impact of cause and effect of stroke and Alzheimer's. We really want to make sure that we exclude those things. One thing it does when you exclude people from the cohort is it makes your cohort number smaller. Like I often tell people, it's not about how big your cohort is. It's about who's in the cohort. Are they the right people? And if they are the right people, well, that makes things really easy, right? Because you can run a really clean analysis. If you've included a bunch of people with mediators and effect modifiers in them, you're going to have much less clarity and a lot more wacky results going on. Anyway, it improves the internal validity, but may reduce the generalizability because you're excluding people who may have some sort of related factor going on in their work. or in their health case. Really, really shortly, if a variable distorts the association between pre-existing differences, match it to reduce that distortion. If a variable defines a distinct clinical context or causal pathway that is related to your outcome, exclude it. It's the best kind of guidance I could come up with for that. So once you've selected all of those factors and you've brought them in, you looked at your baseline comparison statistics to see if there were really statistical differences between them. You can now run, using the balanced cohort menu over here, a little, think of it as like a simulation of your propensity score model. And what's useful about this is before you spend all the time adding all of these propensity score features to it and looking across it and making sure you're getting everything in there, you can use this feature to determine whether your model is actually going to help you control for some of that variance. You can see here that it loads in all of those factors that you've starred, male, female. In this case, I've included a number of mental and behavioral disorders due to psychoactive substance use. I'll tell you a little bit about why you shouldn't do it exactly this way in a moment. But the agent index as well, which is a continuous variable. You can also see these are binary variables, whether the person is male or not, is female or not, or has one of these codes or not. Continuous, again, means 1, 2, 3, 4, 5, 6. So it's going to try to continuously match ages between these two cohorts as it goes. When you hit the run button up in the top right, it's going to generate a couple of things. The first is this graph on the left, these two graphs. It's going to seem a little arcane, but once you understand what it's telling you, it's actually quite useful in assessing how effective your model is in reducing the differences along the factors that you're looking at. So in this one on the left, you can see that your purple line represents cohort 1, your no statins group in this case. So whether it's your control or your experimental group, you can see how they're scored generally. So most people in the model are under 0.1 in terms of belonging to this stat. That means there's not a lot of propensity in this case to be grouped into one group or the other, or into group 1. And you can see, though, in group 2 that because of the way we've defined it by having statins, there's a lot of propensity for being in group 2. So you can see that the scores, the distribution of scores is a little higher between the two before matching. So what you have is because these curves are not overlapping, there tells us that there's, at the outset, a pretty big difference about whether somebody is in group 1 or group 2. There's something going on in all of the factors within these two groups that needs to be accounted for. And if we don't account for them, we're likely to just be seeing a bunch of random stuff in our final outcomes. Over on the right, you can see, though, that after propensity score matching, using the factors that we've included, there's a lot more of an overlap. You can see there's nice, almost no purple showing up over top of the green. It's a little bit of a green-purple mix right here that's really nice. And that indicates to us that we have a lot of people now who are distributed roughly differently from each other in such a way as to be equally likely, or let's say not statistically significantly differently likely to be in one group or the other. Well, how do we know that? This model doesn't work that well because I'm using such large groups of people that the p-value here doesn't really compute as well. But basically, what you're going to want to see is, in most of your analyses, actually this works for the agent index really well, before matching, over here on the left, when you can see by each of your factors in this table that comes below, before matching, our groups of folks were very differently aged between the two groups. One group was the propensity of people in group 1 was to be much younger, right? They were much more likely to be in group 1 and much more likely to be younger than the people in group 2 who were much more likely to be older. And thus group 2 was defined by its likelihood of being older. And you can see that our standard difference that we talked about a little while ago, 1.1, is quite a big difference between the two, and they were statistically significantly different. Now, after matching, you can see in this column over here, our mean ages between the two groups, because we had such a large control group and even such a large experimental group, our statins group, we were able to find one person for every person in this group to be matched with. So you can see that our original pool had like 2.9 million people, out of whom were versus a smaller pool of statin users with 168,000 people. After matching, it's pulled 168,000 people from those 2.9 million people to compare 1-to-1 against the other people in the group. And it's managed to create a distribution of those ages. If you look at it as a logistic regression, a distribution of ages that is not statistically significantly different, that has a p-value of 1, right? As not statistically significantly different as is even possible. And the standard difference between the two is 0.0001, meaning that there's really, really no difference in terms of bias, or in this case, we might think of the distributions of ages in the two groups are not different anymore. And it uses the natural log and a logistic regression to determine what that should look like. Same with male and female beforehand. There were a lot more differences between the two groups. It wasn't exactly 50-50, right? You had 58% in one group and 49% in the other, which makes me wonder about some of the math going on in there. And you had 39 and 49% in this group. And you can see that those are statistically significant before, but after matching, they're not. We actually have, in this case, it got very close to almost identical numbers, but you can wind up in situations where, oh, I know why that actually happened. It's a little complicated, but some people got excluded from this study prior to the window. So that's pretty much how to read the propensity score matching results, which can be really valuable. And this is really important for understanding what's going on in your numbers. But please do note, this is actually a little bit of a birdwalk in case you have done this before. You're going to see when you're doing your propensity score matching model here, your simulation, that you can uncheck some of these boxes. This does not, I want to just be clear, unchecking the boxes on this screen, the propensity score matching inputs screen, does not remove them from your overall propensity score model that's going to be applied when you do your outputs later on, you do your outcomes later on. It just removes them from the simulation, so you can run it several times to see which combinations of factors yield statistically significant results, or sorry, not statistically significant results, and which ones don't. And you can remove ones later on. To remove them, though, you have to unstar them from your saved characteristics window in your characteristics component. That's the only way to remove them from your analysis later. You can't do it from the left. You have to do it from the right. Uncheck those boxes from that start menu. So I just wanted to highlight that because it can be very confusing for some folks using the interface for the first time. You might be thinking, all right, well, cool. What if I don't want to do this? What if I just want to skip this process? Or sometimes people do propensity score matching. They go, well, when my numbers were statistically significant before I ran my model, I don't want, and now I'm using my propensity score matching model and it's no longer statistically significant. I don't want to use propensity score matching for this. I just want to report my unmatched version. Well, here's why you shouldn't do that. Provided you do a good job on your propensity score matching model. Here's what mine looks like without propensity score matching. If you propensity score match, if you do not propensity score match my statins versus no statins group, what it looks like is that the statins group winds up with Alzheimer's at much, much higher rates than the no statins group, which maybe that's true, right? Maybe that's the correct way to think about this, because maybe being on statins just means you're a sicker person generally. You've got all sorts of stuff going on with you physiologically that means that you're more likely to develop the range of outcomes that are likely to be associated with Alzheimer's disease. However, it could also just be that in this case, my group is older, and if you're comparing the no statins group, you could remember from a moment ago, they're much younger on average. They are much less likely to develop Alzheimer's disease at that age, at our age of index and going forward, so prior to our age of index. And we might just be mistaking the fact that we have a group of people who have a lot more comorbidities going on here than our statins group. So if you use propensity score matching and you use a bunch of the different variables, I included things like trying to control for triglyceride and LDL values, and trying to obviously propensity score match by age and sex and race. So if you can propensity score match for just those factors alone, you wind up seeing that the data has flipped, that now the statins people are getting much lower rates of Alzheimer's than the no statins people. No statins people are getting it at almost 1.5 times the rate of the statins people, thus indicating that there's perhaps a protective effect of statins against Alzheimer's, right? And you can see that our actually our numbers aren't that much different along the lines in terms of confidence interval. I'll teach you how to read these tables later next week when we look at the actual outcomes. But this is mainly the most important thing I want you to take away is if you don't propensity score match, or at least very strongly understand why you are or are not propensity score matching for your results, you may wind up accidentally reporting exactly the wrong outcomes, right? We might have confirmed that guy, that internet clown's idea that doctors are overprescribing statins and that statins are causing Alzheimer's disease in our otherwise brilliantly designed study. But that's not what's actually happening. The opposite of that is happening. That's actually potentially protecting people from that. And so you can see here, though, one thing I want to point out was prior to the start of our propensity score matching, we had two pools of people, 3.3 million people in pool 1 and 172,000 people in pool 2. Following that, TriNetX has selected 167,000 people out of that pool of 3 million to go with that 168,000 people from the main statins pool to propensity score match them with. So for every one person who meets a particular set of criteria in group 1, there's a matching person in group 2 who has a similar profile. And that helps us to see a much clearer, truer result than we had previously. So it does a good job of equalizing the study and preserving power. There's some other ways we could have done this. In fact, one way I did it was you could shrink the age range from 45 in my study to 65. So similarly, a lot of people are doing things with their projects where they're looking at non-pediatric populations. So they're just looking at anybody over the age of 18. But a person who's 18 is very different health profile-wise than a person who's 65. So you might want to consider what is a truly representative age range that you might want to use. If we shrank that, though, I did the math and I'm like, well, we lose some of those early onset cases that are actually really important for one of our outcomes, but we would preserve more power. We'd have a much clearer signal if we had a smaller group of people in our control group or our large pool. You can look at groups separately, maybe dividing men and women into separate comparison groups because they clearly have different risk profiles for what's going on here. And that could be something to consider. And you might want to go and remove more confounders, go back to the cohorts and take out more potential, sorry, not confounders, but mediators, things that might be getting in the way of us getting a crystal clear signal of what's going on with our cohorts. So propensity score matching isn't the only way to control for some of these sources of error, some of these confounders and some of these complexities that we're looking for, but it is a very good way to do it. Sometimes, though, I want you to be aware that you can't propensity score match your way through certain kinds of configurations that have too much going on, that you might have a pool of 2 million or 4 million people and no amount of propensity score matching against those random individuals is going to help you create a good control group for your people with retinopathy who are between the ages of 60 and 75. Like, that's a very specific pool of people, and there's probably no way to pull out a good comparison group from that larger pool, no matter what you do. And you're going to have to just define your question and define your groups more narrowly to get a better signal. Thank you for, I've been doing a lot of talking today. I just want to cover a couple of common questions and errors in propensity score matching, because this is really important and central to how we do good quality projects. A lot of people are very tempted to add these top level codes. And what I mean by that is when you first open up your diagnoses options on your propensity score matching, your characteristics menu, you're going to see, oh, look, I can just control in one click for all endocrine diseases or all diseases of the nervous system. Well, the reason you really shouldn't do that is because in TriNetX, if you select all of these characteristics at this top level, all diseases of the circulatory system, for example, in this case, all diseases of the nervous system, and you select that as one of your propensity matching features, it's going to include everything under there. It could choose anything from those characteristics. And as you'll find when you're working with this platform and you see what's going, how ICD-9 codes, or sorry, ICD-10 codes are structured, G00 to G99, if you selected that whole thing, TriNetX might grab one person who has cerebral palsy and another person who has, I don't know what, epilepsy, and another person who has Parkinson's disease. And that's really not getting you where you want to go. It's actually making your model less accurate by just throwing in it, even though we can see from our purple and green bars over here in our signal bar that there's probably a lot of stuff going on in that group. Matching at this level is not going to get you the more specific kinds of answers you want to do. So please do not do that as a start. The better way to do this is to dig in. You can see here at the top level is E00 to E89, which is endocrine, nutritional, metabolic diseases. So this disease, this category of diseases has everything from thyroid diseases, Graves' disease, all sorts of stuff like that, hyperlipidemia, other metabolic disorders, all sorts of stuff is in here, and includes even diabetes, right? However, if you selected even this higher level diabetes, E08 to E13, it would pick people for your propensity score matching model who have either type 1 or type 2 diabetes. It's going to pick them and weight them just the same in your final group, which might be okay, but bearing in mind, type 1 and type 2 diabetes are very, very, very different diseases, right? With different etiologies and different impacts. So if you really do want to exclude type 1 diabetics, then you should select that and select your type 2 diabetics. Don't be lazy and pick the top level category just because that's what you think you want to include. In fact, there's even more subcategories within type 2 diabetes that you might want to look at. And you might want to include or exclude those depending on what you're working on. So you really have to think about how you want to structure your propensity score matching model when you're doing this. So selecting codes at the right level is crucial. As I said earlier, do not use the signal icon mindlessly while doing this. Signal icons are weighted, meaning that they can show high levels of difference between otherwise similar groups. You can see over here, encounter for supervision normal pregnancy, as I said earlier, has a very small difference between these two groups. But if you select that, because it's just got, if that's relevant, by the way, for your study, and you don't mind it selecting all of these subcodes as well, go right ahead, more power to you. That's a good way to go. However, if it's not relevant to your study, doing it can just be additional work for that. It'll be additional variance being added to your study for no reason. And it can actually drive what's called model overfit, meaning that in the quest to just throw everything into your propensity score model, you can actually start getting weird distortions where it starts picking people who aren't good fits for your study because it's the amount of propensity score, or rather the propensity score assigned to each individual is all wacky. So it's something to think about as you're going, is to be very deliberate and use the signal icon mindfully, not mindlessly. Finally, this is a note on codes to use, codes not to use. While some studies do include these codes for their propensity score matching, I do not recommend propensity score matching for the following non-categories. First, in demographics, I see this a lot as a common error. Please do not do it. They use current age instead of age at index. There are potential kinds of studies that you might want to use and propensity score match for current age by, but for the most part, most people should use age at index. That is, when the person started in our study, we want a propensity score match for how old they were then, not how old they are now, right? That study, that index event could have occurred 20 years ago, long before we have any interest in what was going on with them. And we would want to start with their age then and not match them by their current age. Not to say that there aren't reasons that you wouldn't use that, especially if you're doing certain kinds of medication research. Another one is unknown sex. Don't use it because it doesn't mean the person doesn't know their sex. It means there's no record for what sex that person has on their record because either the health system didn't collect it or they didn't check that box or whatever. It does not mean transgender or anything else. Same with not Hispanic or Latino. It's not a characteristic worth using. You can use Latino or Hispanic or Latino because that's kind of positive, makes sense. Non-Hispanic or Latino includes everybody else basically on there who's not part of one of those ethnicities as the US government defines it. Similarly, unknown ethnicity is also not worth using because we don't really know what it means. It might mean that the person didn't include their ethnicity on their hospital intake forms or their health system intake forms because there's no box for them. Or it could mean that they don't believe in ethnicity or whatever. We don't really know. So don't include it because it's not really adding anything to your model. Same with unknown race or other race. We really just don't know what those mean, and they're not really adding anything to your model. Other race could mean that the person's biracial, or it could mean that they believe themselves to be of an alien race. I don't know. We really have no clue what that refers to. Same with unknown race. It might mean they just didn't check a box, right? Other things I would highly recommend being very careful about using are R0 to R99 as propensity score matching factors, because literally every part of the symptom, signs, and normal clinical and laboratory finding, abnormal clinical and laboratory findings, those are all of your physiological, your history and physical stuff could be included in there. And there's really no way to know what some of these things mean, whether the person showed up and had labored breathing, right? Unless you want to include that as one of your cohort definitions, that might be the way to go. But they don't really, none of these things really make valuable or useful propensity score matching characteristics. Z99, however, has a lot of useful stuff in it. There are things in there related to people's social history, their health history, whether they've been homeless or are homeless, unhoused, or any other factor like that, whether they're facing food shortages or housing insecurity or any of those kinds of things. You can find that in the Z codes. However, you have to be very careful in how you use those and integrate them in your model, or you could wind up distorting your statistical model. So I've been doing a lot of talking. That's pretty much all I got for today. And that might seem like a little bit of a cliffhanger to end you on, like, well, why did we just spend all this time talking about propensity score matching? But it's essential because next time we're going to look at how propensity score matching can really make or break, or sorry, how you can move on from propensity score matching to really make or break your study and ensure that you do a really high quality job of getting to your outcomes. We're going to talk about all the different statistical measures that are produced by TriNetX, and we're going to look at what they mean and what they mean for your studies. So that's all I got today. I want to thank you for attending. I'm going to stop the recording, and you guys can feel free to ask questions or